एक मिनट तू क्या फेस फेस देखा है मुझे फेस देख रहा हूँ लेकिन नहीं देख रहा हूँ
हाँ फेस दिखता है क्या सर का चालू करने को बोला नहीं यहाँ पे क्या है कि पीपीक्यू में इसमें पावर पॉइंट में तो हाँ तो जो भी सामने है वो सबको पढ़ना पड़ेगा ना सर यस सर स्टार्ट कर दो
Good afternoon everybody. So today this is a webinar arterial hypertension. Before starting the main salient features of these guidelines, I would like to highlight a few points about hypertension and the global burden it is having. Hypertension in any country, whether it be rich, poor, whether in Southeast Asia, Pacific areas, Europe, only 40% of the patients of hypertension are really diagnosed. And out of that, only 35% are controlled. So rest of the patients are moving around with their blood pressure and they are having target organ damage or hypertension mediated organ damage, and they are at risk of CV stroke, CV deaths, heart failure, angina. So hypertension burden in India, if we can just extrapolate from the surveys, in India, the 1 in 3 urban person is having hypertension, blood pressure, and only 10% of the blood pressure patients are controlled. And in fact, they say that 57% of the deaths due to stroke are due to hypertension, and 25% of the coronary artery deaths are due to hypertension. So this is the burden of hypertension, and let us see what the ESH guidelines have to say about hypertension. The agenda of the whole meeting is we will be classifying the hypertension according to the level of blood pressures as normal, optimal, normal, high normal, stage 1, stage 2, stage 3. We'll classify the risk and the grades of hypertension. Then we will see what is the importance of office and out of office blood pressures. What are the treatment threshold? What is the threshold? Threshold is that when to start treating the patient. And then what are the treatment goals once we have started treating the patient? And then there are few certain conditions of hypertension, like hypertension with CAD, hypertension with CKD, hypertension with angina, hypertension with heart failure, and that we'll discuss in brief in this webinar. So office blood pressure should be measured repeatedly. One single measurement is not important. For a blood pressure of 130, 139, 85 to 89 mmHg, drug treatment may be considered when severe risk is high. So this is a high normal. It cannot be treated immediately. Only if the severe risk is high or the patient has CAD, we should treat this. For patient greater than 65 years, the SBP goal is 130 to 140. And BP in other patients below 65 years, BP should be lowered to less than 140/90 in all patients. And once this goal is achieved, you can still reduce the goal or go to less than 130/80 for most of the patient, except those as we discussed above 65 years. Diastolic blood pressure again should be less than 80 mmHg for all the patients, independent of the level of risk on comorbidities, but it should not be less than 70. And one more important feature is initiate antihypertensive therapy with a 2-drug combination, and that too preferably in a single pill combination. These are the salient features with which ESH started. So first, let us classify, and in the 2013 ESH guidelines classified as optimal, normal, high normal, grade 1, grade 2, grade 3, and one is isolated. The same, the ESH 2018 has maintained the same target treatment thresholds or maintain the level to classify the patient as having hypertension. So optimal is less than 120 and less than 80. The normal blood pressure is 120 to 129 systolic and or 80 to 84. High normal, this is 130, 139 and or 85 to 89, which JNC classified as pre-hypertension. They have put it as high normal. And grade 1 hypertension is anything above 140 up to 159. Grade 2 hypertension, anything greater than equal to 160 up to 179. Grade 3 hypertension is greater than equal to 180, or diastolic greater than equal to 110. And then there is an entity called isolated systolic. So any of the two, remember, any of the two, even if the diastolic blood pressure is higher, above 110, the systolic is less, you can call it as grade 3 hypertension. So highest level of diastolic or systolic can be taken, and that is taken. And then there is an entity called isolated systolic hypertension, in which the blood pressure, diastolic blood pressure remains low, that is less than 90, but the systolic pressure is greater than equal to 140 milligram. And again, the same grades apply for isolated, like grade 1 of greater than equal to 140, grade 2 greater than equal to 160, and grade 3 is greater than equal to 180. So this is how the classification of office BP. Remember, this is office BP and not home BP. And this is another classification of hypertension stages according to the BP levels, the presence of severe risk factors, and the comorbidities. So hypertension is staged into stage 1, which is uncomplicated, stage 2, which is asymptomatic disease, and stage 3, which is symptomatic disease. So if you see this slide, the last column, which is in the red, all patients who are having systolic blood pressure greater than equal to 180 and diastolic pressure or diastolic pressure greater than equal to 110 are high risk. And the same if the patient has a very high risk, if the patient is symptomatic CVD, CKD grade greater than equal to 4, or diabetes mellitus with organ damage. So all this stage 3, if you see the last row, which is considered as very high risk, are having CKD grade 4, diabetes with multiple organ damage, or symptomatic CVD. And rest of the patients are in between low, moderate, or high risk. And then there are two categories of low risk, 2 or 3 categories of low risk. One is a high normal BP, which is 130 by 139, with a diastolic and or a diastolic of 85 to 89. They are called low risk if they have no risk factors. Or even if grade 1 hypertension, that is 140 to 159, and a diastolic blood pressure and or diastolic pressure of 90 to 99, is a low risk patient if they don't have any risk factors. Even if the patient of high normal has 1 or 2 risk factor, still it is called low risk. So this is how, and we will, as we go further, we will know that why to risk stratify the patient. But so the blood pressure, besides blood pressure, you have to find out whether there is a presence of other severe risk factors like diabetes, dyslipidemia, family history, smoking, and other comorbidities. And also hypertension mediated HMOD, which has been shown here. HMOD is hypertension mediated organ damage. What are the organs that are damaged? The brain, the eye, the heart, the kidneys, the peripheral vessels, the heart vessels. So this organ, whether they are damaged or not due to hypertension, that we have to find out in all hypertensive patients before starting the treatment. So here is a comparison. This is just a slide which is kept here because to let you know that all the treatment targets as well as the treatment thresholds are put in according to the office BP. But here is ABPM and high BP, home BPM. ABPM is ambulatory blood pressure monitor, and HBPM is home blood pressure monitor. So these are very important now according to the guidelines, though there are no outright clinical trials showing that what are the targets and thresholds according to the ABPM and the home BP monitor, but they have come in a big way in the sense that they can identify white coat and masked hypertension. They have stronger prognostic evidence. The nighttime readings are taken by ABPM, which is not taken by any other office BPs or home BP. And this is a measurement in a real life setting in ABPM. So patient is moving around in the office, everywhere, eating, drinking, and the blood pressure is going. We measure the blood pressure every half an hour for the whole day, and in the night every 1 hour. So abundant information and multiple measurements are taken during that single session of 24 hours, and the patient is called back after 24 hours, and the measurements are seen on the computer and they are recorded. But the disadvantage of ABPM is it's an expensive tool, and as some limits, so it's an expensive, is not available everywhere. Though now it is not so much a rare thing. Even I have it in my OPD, and we do it in patients where we feel that there is a white coat or masked hypertension. And another disadvantage can be uncomfortable, especially at the night when the patient has to wear it and sleep. The home BP, in the sense, is slightly more comfortable. It is cheaper, widely available. It can also identify the white coat and the masked hypertension, and the patient himself measures it, and there is an engagement. So the patient feels that he is measuring it. The adherence increases. The motivation to control the blood pressure increases, and longer times the patient can measure repeatedly, 1 day, 2 day, week, 15 days, months. The patient can go on measuring. But the disadvantage is it's an only static BP. So it is not a real-time life-setting BP as in ABPM, and then there is a potential for measurement error, and the nocturnal readings are not there in home BP. So why this is kept here? Because these are the two, ABPM and home BP are two things which can find out what is masked hypertension and what is white coat hypertension. Let me just give an example of a masked hypertension to you. Just 7 days back, I had a patient who came with a BP of 132/78. So it was in a sitting position, backrest in my office, and it seemed normal. But he had complained of some chest discomfort and dyspnea on exertion. And so I just got his ECG done, and ECG showed LA enlargement as well as LVH with strain. So this was very discrepant. Though his BP in the clinic was normal, there was something which was showing that he has some hypertension mediated organ damage, which was LVH. So what we did is, in this patient, we told the patient that your in-office BP, that is a clinic BP, is normal, but you require out-of-office BP measurement, and we gave him ABPM for the next 24 hours. And when he came to us for after that 24 hours, we saw his recording, the continuously half-hour recordings as well as a nocturnal recording. Most of the recordings were above 170, 100, or 170, even 110 diastolic. And so this is what is masked hypertension. The in-office BP is normal, and the out-of-office taken by ABPM or HBPM is abnormal or very high. The similarly white coat hypertension, where the in-office is very high, as soon as the patient takes the BP at home, or if the ABPM is taken, it is normal. So these two entities have come in a big way, and we should use it so that not to overtreat the patient, as well as not to miss the masked hypertension, which can cause, which has a bad prognostic CV risk. Let's see the screening and diagnosis of hypertension according to the out-of-office measurement, out-of-office BP measurement. One is the optimal BP, that is less than 120 to 8, less than 120/80, and in that patient you don't have to do anything. Repeat the BP every 5 years. Then there is a normal BP 120/29/80/84. Repeat BP at least every 3 years, and then high normal BP 130/139. 85/89, and this is considered if the patient has a hypertension mediated organ damage. So in this patient, we see whether the patient has any hypertension mediated organ damage, or if it is there, as I showed in the first patient which I told you, then you have to consider as masked hypertension. And in this patient, out of office BP measurement is important, ABPM or HBPM. And if the out of office BP shows high blood pressure, then we have to start treating the patient. If it is not, if it is everything is normal, then again you have to repeat the BP at least annually in high normal BP also, unless one indication to treat this high normal BP are patient having very high risk or CAD, then you can treat the patient along with lifestyle. Then the last category is hypertension, which the threshold remains same to start the treatment, that is greater than or equal to 140/90. And if there are patient is having comorbidities and hypertension mediated organ damage, we can start treatment right away. But if the patient is just 140, in between 140/15, and that is stage 1 hypertension, then we can call him for repeated visits for office BP measurement, or better way is out of office BP measurements with ABPM or high BPM, and if anything out of it is positive, then we start treating. So this is initiation, when to initiate once you have labeled the patient. So a high normal BP of 130/139 by 85/89, lifestyle is advised. Lifestyle, what is lifestyle? Lifestyle is restriction of salt intake, increase potassium intake, increase fruits and vegetables, reduce saturated fat intake, and regular physical activity, moderation in alcohol, and cessation of smoking. These are all lifestyle, and according to the DASH theory, they have shown that if you follow this lifestyle, you can reduce your systolic BP by 8 to 10 mm of Hg, which is a very significant reduction. But in this patient also, if the patient has a high CV disease or especially CAD, then you need to start a single drug, mono drug, along with lifestyle to reduce the BP below 130. And then this is grade 1 hypertension, which is 140 by 159 or 90 by 99. Again, the same thing, you can follow the lifestyle advice as long as there is no HMOD, that is hypertension mediated organ damage, or no comorbidities, a patient is a low moderate risk, then 3 to 6 months of lifestyle intervention can be tried. But if the BP is still not controlled, then you have to start treating the patient with drugs. Immediate drug therapy is only advised if the patient is a very high risk with CV disease, renal disease, or HMOD, that is hypertension mediated organ damage. Grade 2 hypertension, there is no need for waiting. You need to start immediate drug treatment in all the patient, and along with lifestyle. Of course, lifestyle remains. Lifestyle is complementary. You cannot just give drug and not advise lifestyle. Just as you give lifestyle advice in diabetes, the same lifestyle advice you have to give in hypertension patient to get optimal control. And the aim is to bring it within 3 months. Similarly, for grade 3, there is no doubt we have to start with lifestyle along with immediate drug therapy. So let us see what is the core drug treatment for uncomplicated hypertension. So according to the ESH, consider monotherapy in only 2 kinds of patients. One is a low risk grade 1 hypertension, that is 140, 150, less than 150 BP, along with no other comorbidities, no hypertension mediated organ damage, or in a very old patient greater than 80 years or frail patient, you can start with a single drug. Otherwise, most of the patients, you start with a dual therapy. Dual therapy is ACE or ARB plus CCB or diuretics. This is in a single pill combination. Wait for 3 months. If it is not getting control, you can go to step 2. That is single pill, 3 drug combination. Now, we are using, in India, we are already using single pill combination. But European society has now realized that single pill helps in increasing the adherence of the patient, because the patient has to take just a single drug once whenever it is given. So 3 drugs in a single pill. So single pill combination of 3 drugs, ACRB plus CCB plus diuretics. And if still it is not controlled, then we have to go to step 3. Either you can consult a referral for further investigation, or add spironolactone, which is a 4th drug, or alpha blocker, other diuretics, or beta blockers. Remember, beta blocker has gone as a 3rd or 4th drug because of its side effect profile, because of a new onset of diabetes with beta blockers, less improvement in the hypertension, less regression of the hypertension mediated organ damage. But still, there are certain compelling indications of beta blocker which we should remember. Like if the patient has angina, if the patient is post-MI, the patient is heart failure, if he is having atrial fibrillation, or planning or with pregnancy, then beta blocker becomes almost a 1st or 2nd line drug for that patients. So initial therapy, dual drug combination, RAS blockade CCB. Step 2 is triple combination, RAS, CCB with diuretic. And then the step 3 is triple drug plus MRA, that is mineralocorticoid receptor antagonist, either aldactone or apleneron, or you can give alpha blocker, beta blocker. Now, what is the treatment for hypertension with CAD? The patient has now a comorbid condition, CAD. So in this, now there are some certain compelling indicators. Here, beta blocker comes 2nd. ACE inhibitors plus beta blocker, or you can give beta blocker with calcium channel blocker, or beta blocker with diuretic. Monotherapy is only given, again, your monotherapy doesn't stand. You have to give the patient, monotherapy can be given in a very frail patient. The patient is not still controlled, you can start giving 3 drugs. That is a calcium channel blocker, beta blocker, and an ACE inhibitor can be given. And a step 3 is triple drug, which we have already given. Plus, you can add spironolactone to this patient in the dose of 25 to 50 milligram. And this is how you go for coronary artery disease. So beta blocker comes up in coronary artery disease. In patients with CAD, the target is, what is the target? Less than to 130 and lower. And if the but not lower than 120. One Accord trial has already shown that if you lower the blood pressure below 120, then there are adverse CV events. So don't try to over treat the patients. To target diastolic blood pressure less than 80. So 130 and 80 should be the ideal target. In older patients, those who are greater than 65 years age, target the systolic blood pressure range of 130 by 140. So that there you can slightly be lenient. Again, hypertensive patient with history of MI, beta blockers and RAS are recommended as part of treatment. So these are the two integral part of treatment. And in patient with symptomatic angina, beta blockers and calcium channels are as a class 1A evidence. So hypertension and CAD dual RAS plus beta blocker or RAS plus CCB, and step 2 triple of the above, and step 3 above triple the 3 drugs calcium, beta and RAS plus MRA has to be given. Now there is hypertension and CKD. Hypertension is the second most common cause of CKD after diabetes. So once the patient is having CKD along with hypertension, you start ACE. ACE still remains the drug of choice, but calcium channel blocker is a better drug here, and ACE with calcium channel blocker or ACE with diuretic. If you have the GFR which is less than 30, then a thiazide or thiazide-like diuretic doesn't work, and then you have to give a loop diuretic in that patient. If this is not controlled, again go to step 2, single pill combination. Remember, all are single pill. First 2 drugs in a one single pill, and then second step again 3 drugs in a single pill. So then you go with ACE, ARBs or ACE plus CCBs plus diuretic or a loop diuretic. We already have this combination available in India. Now European Society and in Europe also widely this combination of ACE with CCB and diuretics are available. And still, if the BP is not controlled, again go to step 3. The triple combination along with the spironolactone can be added. And again, as on the seen on the right side, the beta blockers remain the drug only. There are specific indications like heart failure, angina, atrial fibrillations, and patient planning for pregnancy. Then you directly add a beta blocker. So this is in CKD. CKD, again, it is recommended to bring the blood pressure, systolic blood pressure to less than 140, 130 to 140 is class 1A evidence, and individualized treatment should be considered depending on what is the renal function and electrolyte, because ACE inhibitors also, giving ACE inhibitor can sometimes increase the serum creatinine levels to about 20% or 30%. But still, RAS blockades are more effective, especially if the patient has presence of microalbuminuria or proteinuria, and they are the drug of choice in patients with hypertension and CKD. A combination of RAS with CCB is recommended as initial therapy, or a combination of RAS with the diuretic. Remember, combination of 2 RAS is not recommended. It can cause impairment of the renal function. It can cause dangerous hyperkalemia. So ACE inhibitor along with ARB should not be combined in any stages. So hypertension, as we saw, RAS plus CCB or RAS plus diuretic. Triple drug is RAS plus CCB plus diuretic, and step 3 is above plus MRA, that is mineralocorticoid receptor antagonist, that is aldactone, spironolactone. Now, another entity, hypertension is one of the commonest cause, if untreated, is commonest cause of heart failure. Is almost, it accounts 40% of the heart failure. So if the patient has hypertension with heart failure and reduced ejection fraction, R is reduced ejection fraction, then the initial therapy again stands ACE inhibitor plus diuretic, or if the GFR is less, then you can give loop diuretic, or there is edema. Edema is the patient is fluid overloaded, and loop diuretics are better than the thiazide-like diuretics. Plus beta blocker. We all know that we use ACE inhibitors and beta blockers, both the drugs in heart failure. So these are again used for hypertension in heart failure. The step 2, again, all the 3 drugs can be combined, ACE or ARBs along with diuretics and a beta blocker. And of course, the 4th drug always MRA, which is a very good drug in patients of heart failure. So one caveat is that when antihypertensive drug is not required in hypertension, heart failure with reduced ejection fraction, then you can give a combination of angiotensin receptor naproxen inhibitor instead of ACE or ARB according to the ESC heart failure guidelines. That is a sacubitril with a valsartan combination that has come up in a big way. So here the therapeutic strategy in hypertension with heart failure or LVH is with heart failure with reduced or preserved ejection fraction, BP lowering should be considered if once the BP, the treatment target remains same, greater than 140 by 90. With reduced ejection fraction, BP lowering should be done with the ACE or ARB and a beta blocker and a diuretic and even mineralocorticoid MRA if required, because this is a good drug. Remember, dihydropyridine CCB may be added if BP control is not achieved. Otherwise, here calcium channel blocker has no role, because calcium channel blocker they have shown that they are not good for patient with heart failure. So it is almost added as a fourth drug when the blood pressure is not controlled, not for heart failure. In patients with high heart failure with preserved ejection fraction, BP treatment targets, thresholds and targets should be the same as for a reduced ejection fraction. The threshold remains same, 140 by 90, and target also remains less than 130. And all major drugs can be used. As we showed, the calcium channel blocker comes as a fourth drug here to control the blood pressure. In patients with LVH, again, the same thing applies. RS in combination with CCB here and or diuretic. And again, the systolic blood pressure should be lowered below 130 in patient with hypertension with LVH. Here is a patient of hypertension and atrial fibrillation. Remember, atrial fibrillation, now what we will call atrial fibrillation is an entity where which can be diagnosed, not diagnosed by automated. When we were talking about blood pressure, there are two things which I wanted to share with you. One is office BP and out of office BP, which I already told you why they are important. And another is the machine use. Normally, most of the times, most of the Indian doctors are using mercury BP machine, which is now getting out of date, and mercury is in fact banned in India. And now the trend is to use the automatic BP which are available, and that uses the oscillometric method. And in fact, I use it in most of my patients in my office as well as in for home BP monitoring also. But why I took this here, because in patients with atrial fibrillation, this is only one condition where the automatic BP, which is oscillometric, can sometimes give error, and there the regular mercury BP is used. Or now there are one or two companies coming with a machine which can detect the atrial fibrillation and can take accurate BP even with the oscillometric method. So there is a hypertension with atrial fibrillation patient. Again, ACE inhibitors, because